I have no disclosures. Anyone wants to give me any money, it'd be great. Thank you so much on behalf of the esteemed colleagues and the organizers for having me do this case and for inviting me out here to Denver where I did some training. All right, let's see if I can get this thing going here.
Is it launching?
It's launching.
Yeah, I think it looks like it's loading now.
All right. I was wondering who would actually get the quote here from Princess Bride. It's showing my age here, so hopefully the panel understands. Conflict of interest, I have none. So I have a 39-year-old sickle cell end-stage renal disease patient, diabetes, presented to the ER complaining of pain in her legs and back as well as generalized weakness. She was actually admitted to the MICU with right foot wound and presumed impending sepsis, given histories of fevers and altered mental status. She's an absolute train wreck. She has every single possible vascular issue that you can imagine. Diabetes, end-stage renal disease, on-home PD. She's got very, very profound calciphylaxis. Her thighs essentially look like almost an IV drug user from black spots all over her legs and arms from calciphylaxis with severe peripheral vascular disease, sickle cell anemia, and she actually had a history of coronary disease, status post a recent LAD stent in the mid-LAD. Her own meds are here. She's got a very supportive family. She's got a history of iodine just to make things more fun. She's actually a good citizen, but just a very, very poor history and bad genetics. She actually came into the ER looking very much septic at 94/58 with a heart rate of 106. She's got essentially a wound out of her foot. I'm sure everybody's thinking I'm going to do a peripheral intervention on her. She's got a 3 by 4 centimeter wound with foul smelling discharge. This is her white count. It's just a mess. White count's 22,000. Her H&H because of her sickle cell is 6.1 on 19. Her creatinine's 12. She's on dialysis, and she's got a lactate of 1.91. So she's admitted to the ICU. This is her baseline EKG. Nothing acute going on. And at 2 a.m., as I'm attending on the CCU, I get this phone call. The patient has VT-VF arrest. CPR is initiated. ACLS is started, and here's the EKG. This is what we got after she was stable, but she keeps going back into VT and VF. She's had amnio on board ×2. She's had 20-plus shocks, and somehow, despite this, and I did ask her what her last 4 was to see if she would answer, she's awake and moving. Here's her EKG. What do you want us to do? And this was the comment from the MICU attending and from our CCU team. So the patient's neurologically awake despite being shocked numerous times. Her mom, who is at the bedside at 2 in the morning, wants her to be full code. She's terrible history. She's younger than I am. She's 39 years old. She keeps getting refractory VT and VF. She's shocked, I don't know how many times by the time I got in. And presumably this is a STEMI. So what do you do at that point? So I thought, given her age, despite her terrible history and our morbidity and mortality, which is tracked nationwide, I figured this is going to be a mortality, but I feel like we have to do our best for her. She's 39 years old. We got to try it. So we tried ECMO. We basically cannulated her at the bedside in the MICU with a 15 French, she's relatively small, right CFA and a 24 French V. She arrested as soon as we got her on circuit, and we transported her to the lab in VF and VT. She has had additional shock. She would not come out of this. Here's our initial pictures, almost a follow-up case of what you just saw, but without the crazy graft. This is entirely in VF. This is her left coronary system. She has a chronic total occlusion of the circ, which is non-dominant. She had a recent LAD stent, as you can see in the midsection. It looks like it has a thrombus in it as well. Probably some acute thrombosis from the low flow, from the compressions, and the long-standing VF-VT. And she looks like she has apical embolization as well, and some collaterals over to the right. Going in, and we went, I normally go radial, but she's had dialysis grafts attempted on both sides, and I really had very little time to move, so we went from the left femoral. This is a AL 0.75 guide. This is obviously not a great-looking coronary artery, heavy calcified plaque in the proximal aspect with diffuse disease throughout. Looks like one PDA that it's filling. So just did some low-pressure balloon angioplasty to try to get some flow. It looks like we're actually getting some flow after POBA. Did additional aggressive balloon angioplasty. Now we're starting to see a little bit more of the lesions. I almost felt like leaving this at one point just to see if we can get out of Dodge. But she, as you can tell here, is still in VF, the entire time. The aortic valve is just not opening. So after more aggressive balloon angioplasty and stenting with a very aggressive post-dilatation, all the way back from top to bottom, this was our final result, which I was going to take. You can see actually the guide's a little bit across the aortic valve there, inducing some severe AI as well. So you have to be careful with that with these Amplatz guides. So at that point, we said she's in shock. We're going to go over to the left-hand system and try to take care of the LAD thrombus. It's actually cleared up with anticoagulation. She's on heparin and a fair amount at this point. Did some aspiration thrombectomy, balloon angioplasty. Again, this is your pressure. She's basically a mean arterial pressure only on ECMO. And this is our final from the left-hand side. After aspiration down to the apex and low pressure balloon angioplasty. So at this point, she had not had antegrade access. I think one of the biggest things with ECMO is to make certain that you have contralateral or an antegrade sheath in. Since we're already in on the left-hand side, what I decided to do instead of try to stick an antegrade sheath in, I would just do a crossover. So I used actually I used an IM catheter, crossed over, and got a crossover sheath, a 6 French pinnacle destination, down past the ECMO cannula. With some use, basically required a Lunderquist to be able to get this thing down. Got it down to perfuse her limb during the same time. So she remained in VF for, again, very similar to the last case, for almost 45 minutes. Her temperature at that point was 34 degrees. And I think one of the things that I've learned on now at Piedmont with a lot of ECMO experience is that essentially you're going to be in VF at 34 degrees. You have to rewarm the body. And so at that point we started rewarming on the circuit. At which point we saw her pop into VT and then successfully cardioverted her in the sinus tachycardia. And so she left the lab in sinus tach. She remained on ECMO for almost 11 days. She was eventually transferred to the MICU, trach pegged. And the interesting part is her family made her comfort care after 2 weeks. She then woke up 2 days on palliative care and demanded full code, completely awake. She recovered from fevers, pneumonia, and numerous complications. And she left to LTAC almost 30 days later, alive, awake, and neurologically intact. So there's a big difference between mostly dead and all dead. So she's slightly alive.